My name is Andrew Minton. I work for the Immunisation Coalition and delighted to be your moderator tonight. There are a few housekeeping things that I'd just like to cover first, but I'd like to recite the welcome to country. I'd like to acknowledge the traditional custodians of the various lands at which we work and welcome all Aboriginal and Torres Strait Islander people that may be participating in this webinar tonight. I pay my respects to and on behalf of the Immunisation Coalition, respects to elders past, present, and emerging. Tonight's presentation, as it is recorded, all participants will be on mute. I see that we have about 250 people online already. We have just over 800 registrations, so I think more people will come online in time. And before I introduce tonight's presenter, I'd just like to just cover a few statistics that I have on my left up here. A few statistics around flu, really depicting the serious illness of influenza, particularly on patients under 5, the adult older population, and with those with medical conditions, particularly underlying chronic medical conditions. So in terms of where we stand with case numbers, and this is the latest information, and I know Angela is going to cover this in one slide, but not all of this, but I wanted to cover the fact that as of the 3rd of April, or year to date, we have just over 30,500 confirmed cases of influenza. If we compare that to the same time last year, which was 18,500 cases, so it's 1.6 times more this year compared to the same time last year. If we go back a few years and just skip the pandemic years for obvious reasons, and I look down at 2019, which had a recorded annual influenza case of 313,000 cases. Year to date, that number was just over 25,000 cases. So we are still 1.2 times ahead of the 2019 moderate to high case year, or if you like, 20% above. And really, just to frame this a bit more, I looked at the vaccine coverage rate for under 5s. I'm just choosing under 5s and not the older population or those with chronic medical conditions. The national average was 28% vaccine coverage for under 5, and that's really quite low compared to other immunizations and other vaccines for under 5, which is up around 3 times more than that. But for influenza, 28%. For the Aboriginal and Torres Strait Islander peoples, it was even less at 19.6%. However, there is good news, and you're probably all aware of this. In the last 24 hours, Minister Shannon Fentiman, Minister of Health, Mental Health and Ambulance Services, through the Queensland government, announced a free flu vaccination program from 6 months old to all residential Queenslanders with or without a Medicare card. So they are calling to, and there will be a messaging campaign around this, I'm sure, to the public, to visit your local GP and pharmacy to get vaccinated. And that was probably triggered by the fact that in the recent months, there's been 700 hospitalized patients with serious illness from influenza, and it's only just the start of autumn, and it's not even really into the pre-winter stage. So that free vaccination period starts from 1st of April and runs through to September. So that's a whole 6 months. So that's really wonderful news. But that's just part of the equation. We really do need to emphasize the seriousness of influenza and get the population and to GPs and pharmacists to get their vaccination. I also read recently that WA, and you'll also be across this as well, again, is offering a free flu vaccination period, this time in the months of May and June. So that's for a 2-month period for 6 months and older adults. And we're waiting to hear from New South Wales, Victoria, Tasmania, SA, and Northern Territory. So we hope that they were able to provide some good news around flu vaccination as well. But I am aware that or the Immunisation Coalition is aware that the states have been working on their 2024 to 2029 plan together with the federal the federal government, particularly around communication and messaging to all Australians. So yes, at the moment we're at 30,500 year to date, which is exceptionally high, and we haven't even got into the winter period. But with the free flu vaccination and recommendations from the government and strong recommendations from your GP, pharmacists and other healthcare professionals that immunise, hopefully we can stem what could be a very high influenza year. So with that said, now taken up too much time, but I just wanted to frame where we stand with influenza before I hand over to our speaker. So Angela Newbound is no stranger to most people, so I'll just introduce her briefly and then hand over to her. Angela Newbound is a nurse and is based in South Australia. She's an immunisation education consultant and also a member of the Immunisation Coalition, and has been for many, many years, and has given many talks for us at major meetings, and has been involved in immunisation program delivery in South Australia for over 2 decades. Angela provides clinical advice, support and education to a wide range of immunisation providers and contributors to the development of immunisation resources to assist providers with challenging aspects of the immunisation program, and that's across the whole immunisation program. Angela is passionate about the role that nurses play, vaccinating against infectious diseases, and regularly presents at IC events, as I mentioned before, to mixed healthcare professional audiences. So I've taken up probably more than 5 minutes of your time. So with that said, the last thing I want to say is we will be finishing at 7 o'clock on the dot, just to respect everybody's time. So over to you, Angela.
Thank you for the kind introduction, Andrew. I'm going to jump straight on into this because I'd like to know where everybody else is coming to us tonight from. So here's your first poll for the night. So can you just please tick a box, whichever one is right for you, just so I know what we've got as an audience tonight. So are you a GP? Are you a nurse or midwife, researcher, educator, pharmacist, other healthcare worker, or something completely different than that? We'll just give you a short little minute. Okay, how did we go? And Susie, we're probably not giving people much time, but we'll see what we've got. Okay, so those that have answered, 12% are GPs or medical practitioners, 78% are nurses, midwives or immunisation practitioners, and we've got 5% are pharmacists and 5% belong to the other group. So thank you very much for letting me know. That's fantastic. Okay, so I suppose, look, I think you know flu exceptionally well. I don't think it's any strange disease to you, for sure. You've seen lots of it, for sure. But look, just a quick recap. It's a contagious respiratory illness. It affects the nose, the throat, and sometimes the lungs. And it's a significant human pathogen that causes, those seasonal endemic infections and periodic and completely unpredictable pandemics that we've experienced along the way. And it's probably one of the most common causes of human respiratory infections. The natural reservoir for influenza A really is wild aquatic birds, particularly ducks and other waterfowl. There is obviously some transmission between birds and through fecal oral route, and those migratory birds, of course, then really potentially facilitate that transmission of influenza over long distances to other birds, animals and human populations. Additionally, Humans, pigs, and horses are natural hosts of influenza A virus as well. And we're going to talk about signs and symptoms shortly, but it's worth noting that, systematic reviews and published studies describing the relationship of viral shedding and disease transmission, which was undertaken back in 2014, found that about 1 in 3 influenza-affected individuals is actually asymptomatic. So disease can look, really very, very differently in different people. So obviously, this is our flu virus. You've got those protein spikes on the surface, and so you've got hemagglutinin spikes, and you've got neuraminidase spikes. And those hemagglutinin spikes, if you like, that's what binds to the surface of its target hosts. So once we become infected with influenza, then those viral cells will roam around, and then eventually those hemagglutinin spikes will help it attach to our human cells. And then that viral genome can then enter from the flu virus into what was a healthy cell. The main function of neuraminidase is believed to be one to remove the receptors for influenza virus from those newly formed virus particles. And that's just therefore allowing these to be released and spread of infection. So hemagglutinin attaches to the cell, lets it get into the cell, and the neuraminidase really facilitates that release of all of those cells. So those cells multiply by the millions, and so once the neuraminidase has facilitated that breakout of the human cell will then die. So it can be a really damaging disease. So we're going to launch straight into our first poll of the actual session and asking you what actually best describes antigenic shift. Is it A, it's that random genetic mutation of an infectious agent resulting in minor changes in proteins called antigens? Or is it B, the accumulation of a series of minor genetic mutations? Or C, viruses that are closely related to one another? This can be illustrated by their location close together on the phylogenetic tree. Or is it D, an abrupt major change in an influenza A virus, resulting in new hemagglutinin or new hemagglutinin and neuraminidase proteins in influenza viruses that infect humans? So let's just see how you go with those choices. I'll give you a quick little minute. And how did we go, Anastasia? Okay, so we're really spread across the board. So for A, there were 26% of you that thought that antigenic shift was those random genetic mutations. 16% of you thought that it was an accumulation of a series of minor genetic mutations. 6% said it was viruses that were closely related, but 52% of you said it was an abrupt major change in influenza A virus, which, causes those changes to hemagglutinins and neuraminidase. And you are in fact correct. It is D is the actual answer for this particular question. So antigenic shift. So flu viruses are classified, antigenically really as types A, B, or C. Influenza A viruses and influenza B viruses, though, are really the clinically important ones in causing human disease. We've talked about those protein spikes of hemagglutinin and neuraminidase, and these play just such an important role. And really they can sort of help us understand how serious the flu illness might be. We know that influenza A and B viruses undergo frequent changes. However, they are very subtle often. B viruses do not change as much as the A viruses do. Very subtle changes, and that's just year to year what we call antigenic drift. But an antigenic shift occurs when there is that radical and abrupt change in influenza A viruses. And, such as when at least maybe two different viruses combine, and that results in that complete change to the hemagglutinins. In other words, if we were to go from a H3N2 to all of a sudden what was circulating was a H5N1, that complete change to what's circulating. And it just sort of really, consequently, really forms this real mosaic virus. So we don't like it when it shifts. We can handle it if it just drifts. So how does it spread? Of course, spreads easily from person to person by, that inhalation of those infectious respiratory droplets produced by an infected person when they talk or when they cough or when they sneeze. Obviously, aerosol transmission, they say, is less usual, but certainly can occur within those confined spaces and during those aerosol generating procedures that you may be involved with. So we also know that flu virus can live really quite happily on a surface, a hard surface, for maybe up to 2 days. And so when you think that 1 in every 3 adults have been observed to either pick their nose or rub their eye every hour, and not just once per hour, one study actually found that happened. They touched a surface, they touched their nose or their mouth or their eyes 3 to 4 times in an hour. So it absolutely pays to continue to promote and practice good hand hygiene. We certainly know that children less than 5 years of age can become infected more easily. They often have repeat infections and they're more likely to transmit influenza. They don't have good cough and sneeze etiquette either, and they do remain more infective for longer than adults do. So on average, around 7 to 10 days versus an adult that's around 3 to 5 days. So children are a worry, and as Andrew alluded to before, immunisation rates for children against influenza are absolutely suboptimal when it comes to, really reducing that transmission. So we know that flu spreads around the community pretty easily. We know that complications can cause lengthy hospitalisations and ICU admissions and deaths. And it's estimated that really flu contributes, to around about 3,000 deaths in Australia each year. And so what deaths and what disease is actually reported to the National Notifiable Disease Surveillance System, we believe is really grossly underestimated to how much disease there is and how many people are actually dying from influenza. So, burden of disease, certainly has changed over the past few years. During our pandemic years, my gosh, we hardly saw any flu circulating at all. Those border closures were wonderful, all the stay-at-home orders and masks, etc., and everyone was on board with the hand hygiene. But of course, our borders then opened in March of 2022, and along with that, influenza returned strong to Australia. It remained high and higher in 2023 because we are pretty much back to normal. It's business as usual. Very few masks are being worn, etc. So it's definitely come back, with great vigour. And, last year, 2023, actually was the worst on record since 2019. When there were 313,647 cases notified in 2019. So if we look at the burden of disease, and this is a lovely graph from the Immunisation Coalition website, and Andrew's really spoken quite nicely to this graph, and you can really see the numbers, that are printed there for you. So we know that we're, certainly up by about 11,500 flu notifications, just over, from the same time last year. So, I think it's going to be interesting to see what the flu year eventually does. Are we going to peak early? Are we going to get out of it early? Or are we going to follow a similar trajectory to what we did in 2023, which is that pale purple line? And you can see that we had influenza all the way through the season, all the way through the year, in fact, even through into November. There were significant more cases being reported. So from those reported notifications, what are the age groups that are mostly affected in 2024? Well, it's pretty much, once again, those young children, once again, high reports of influenza disease. In the first quarter of 2023, there were about 8,000 notifications in children less than 19 years. And of course, for this same cohort, so far this year, we are well and truly above that, with over 10,000 notifications in that age group alone. So what's actually circulating? Well, it's a little bit too early for us here in our flu season to really understand what's going to happen for us. But looking back over the past couple of flu seasons, we can really see that H1N1 dominated, although there was a significant amount of B disease in 2023. And because there's not much subtyping really that's been happening for our season, because it's just so early, we don't really know what we're going to be looking at, to be really quite honest. However, I think if we look at the FluNet data that's currently available to us, influenza A, obviously, and mostly H3N2, and B disease are co-circulating in the Western Pacific region. The majority of cases, of course, reported in those early weeks of 2024 have been influenza B Victoria lineage. And it's just important to note that the Yamagata B lineage has not been reported globally since March in 2020. So, what does it really tell us? Well, it could tell us that we could be seeing a mixture of H3N2 and B Victoria in Australia this year, but no one's got a crystal ball and we don't really know. So we're going to have another poll, and so this is looking at international studies that have revealed that healthcare settings have some of the highest rates of sickness presenteeism. In other words, people coming to work when they are unwell. So can you hazard a guess on what percentage of healthcare workers in Australia admit to going to work with an influenza-like illness? A, is it 40% of us? B, 25%? C, 60%? Or D, 75%? So we'll just give you a quick little minute. Okay, how did we go, Anastasia? Oh, wow, across the board again. So 27% said 40%. 8% of you said 25%, 44% of you said 60%, and 21% of you said 75%. It is actually C, 60%. And this was really according to an Australian National University medical school study that was undertaken back in 2020. That number, jumps up to about 99% for healthcare workers when experiencing minor flu symptoms. So it's a bit of a worry, but we can really only hope that what we have learned over the course of the pandemic could mean that our practices have changed and people are more likely to stay home when they're sick, particularly if they're a healthcare worker. So there's lots of complications of influenza, and I'm not going to karaoke this slide, but I think it's really worthwhile to just say that it can be anything really from sinus and ear infections, can be complications, or they can be, really quite significant complications such as your myocarditis and encephalitis and multi-organ failure, kidney failure, respiratory failure, etc. There's a really big growing body of evidence that suggests that flu virus infection itself could put people at risk of acute cardiovascular events like heart attacks and strokes. And studies have actually found that people were 6 times more likely to be admitted to hospital for heart attack in the week after coming down with the flu compared with any other time. And, there were other studies really that said that risk of heart attack and ischemic stroke in patients aged 50 and older more than doubled in the 2 weeks after even mild influenza in those with few risk factors, and more than quadrupled in high-risk patients with severe influenza. And that elevated risk persisted for 2 months after their influenza infection. And they just believe that it's just that real systematic infection and inflammation that occurs that leads to that endothelial dysfunction, leading to destabilization and rupture of those existing atherosclerotic plaques. So, the number, like I said, is probably grossly underreported. It's a little bit too early, but I did read an article from Queensland today that they've experienced 11 influenza-related deaths already this year. Consequently, probably why they've decided to have a funded program. But certainly, we do really need to take care of people and make sure that they reduce that likelihood of becoming grossly unwell and ending up in hospital, ending up in intensive care, ending up in a coffin, most definitely. Last year was a bad year, 39 deaths for patients that were admitted in, sentinel hospital sites. Out of those 39 deaths, 9 of them were in children aged less than 16 years. And this is a little bit higher, really, than what happened in 2020, where there were 2 deaths, but there were 11 deaths in children of that age group in 2019. So flu is a significant disease, and we need to protect people. So who are the people that we need to protect, really? Definitely children, definitely individuals that are older than 65, and definitely our Aboriginal and Torres Strait Islander people. Some people are really at more risk of experiencing complications from flu, but these groups we need to pay special attention to. Obviously, those with medical risk factors also over 6 months of age, and there's a whole list of those medical risk factors that would predispose someone to severe influenza disease. We'll just take a closer look to at influenza infection in individuals with some of these chronic conditions, and we'll just focus a little bit on those with cardiac disease and chronic respiratory conditions, pregnant women, and diabetes shortly. So I think before we do that, we'll really just have to remind everybody that flu vaccination is recommended for everybody 6 months of age and older. We need to take special care of those in long-term care facilities, and that could be aged care, it could be correctional services as well. And while some groups are not going to be eligible for funded flu vaccine, it is recommended for everybody, and just because it's unfunded doesn't mean that it's unimportant. So we should be just continuing to recommend it to every patient that is seen. So if we look at flu infection and cardiac arrest and cardiac disease in general, I suppose, influenza really does affect the vascular system in multiple ways, and it's associated with that real increased number of pro-inflammatory and prothrombotic cytokines, which causes, like I said, that endothelial dysfunction and leading to that, you know, those plaques falling off the wall, so to speak. So there's just that mounting evidence, and I think that we need to pay particular attention to this, and this is, I think, where a lot of our influenza deaths are not reported accurately, because if someone does die from a myocardial infarct, then that could be the coding that the hospital use, and it's not related to influenza, as the statistics would tell us. But in fact, it may well have been, for sure. So if we're looking at patients with COPD, we know that the mortality and utilisation, I suppose, of healthcare resources associated with influenza is really concentrated in elderly people and those with these, chronic comorbidities, I suppose, and particularly COPD. There's really this, epidemiological and experimental evidence that viral respiratory infections, and particularly those caused by influenza virus, do increase the risk of secondary bacterial infections such as pneumonia. And so we just need to really look at, there is that potential for significant virus bacteria interaction in COPD patients. So more studies, of course, are going to be needed with this, but I think, you're seeing these patients all the time, and offering them a flu vaccine is really important. Asthma is another problem. Flu is definitely a trigger for asthma. It can certainly exacerbate the inflammation of the airways and the lungs, and it not only triggers the symptoms of asthma, but certainly makes them worse. People are not more likely to get the flu because they have asthma, but they are more likely to experience complications related to influenza, such as bronchitis and pneumonia, and often require hospitalisation as a result. Even people with mild or well-controlled asthma are at high risk. However, the vaccine is only funded for patients with severe asthma. And that means that they have multiple medical consultations or have to use multiple medications to manage their asthma. So diabetes, that puts a patient at greater risk of any kind of infection, whether it's viral or whether it's bacterial. And people with type 1 or type 2 or even gestational diabetes, even if it's well managed, are at high risk of serious complications to flu that could lead to hospitalisation and death. It can also make these chronic health conditions worse. And this is really, particularly in diabetics, can make the immune system less able to fight infection. And that acute illness can make it harder to control blood sugar levels, and glucose levels can impact the severity of influenza infection. And hypoglycemia, glycemia is related to the worst outcome in both bacterial and viral infections. So there are a sizable number of people who die from influenza complications that have diabetes when you can compare them to people who do not have diabetes, whether they're the same age, sex, race, or socioeconomic status. So your diabetics are very important people to be offering influenza vaccine into. Pregnant women certainly have been shown to be at that increased risk of more morbidity, as well as mortality. Newborn infants that are born to mums with influenza during pregnancy especially mums that have had severe illness are at increased risk also of adverse outcomes such as preterm delivery or low birth weight. Babies that are less than 6 months of age who experience influenza infection also have high rates of hospitalisation and do account for deaths in children. So vaccinating women in pregnancy not only protects the woman themselves, but also the baby, because we've got to remember that babies under 6 months of age are too young to be vaccinated themselves against flu, so they are going to rely on those maternal antibodies. So the seas and the airs are open again to travel, that's for sure. Flu vaccination is definitely something to discuss with anybody that's going to be travelling. And of course, you'd be having that wider conversation about all of the other vaccines, such as your COVID vaccines and Hep A's and Hep B's, whether they need a pertussis booster, maybe depending on their age, etc., and maybe where they're travelling. May also need to have a conversation about MMR vaccine as well. So really, just to summarise that component there, the handbook recommends seasonal influenza vaccination for everybody 6 months of age, and definitely strongly recommends anybody that has a comorbidity or are in those risk groups to be vaccinated against influenza each year. So this is your third poll for the evening. So who is recommended to receive 2 doses of influenza vaccine 4 weeks apart in the same year? A, is it children less than 9 years receiving flu vaccine for the first time? B, is it individuals having flu vaccine for the first time post solid organ transplant or hematopoietic stem cell transplant? Is it C, women who have already received a dose of influenza vaccine but then become pregnant in the same year? Is it D, all of those above? Or is it E, none of the above? What would you suggest? Give you a couple of seconds there. And how did we go, Anastasia? Oh, wow, very good. Okay, so 29% said that it was just for the children under 9. 3% said it was the solid organ transplant or hematopoietic stem cell transplant. 1% said it was the women having a flu vaccine and then having another dose when they become pregnant. And 64% of you said D, all of the above. And 4% of you said E, there was none of the above. Well, the 64% of you that said D, all of the above are correct. So 2 doses of flu vaccine is recommended in children under 9 years of age receiving flu vaccine for the very first time. After that, they have a single dose each year. For hematopoietic stem cell transplant, solid organ transplant patients, yes, 2 doses 4 weeks apart in that first year post-transplant and a single dose from there on. For your hematopoietic stem cell transplant patients, related mortality is really closely linked to the development of pneumonia. So preventing pneumonia is really important in these individuals. So we need to protect them from flu so they don't get a viral pneumonia that could lead to a bacterial pneumonia. And we certainly also need to protect them with pneumococcal vaccines as well. Definitely, we want women to be vaccinated in pregnancy. So if they've had a vaccine prior to becoming pregnant in 2024, we definitely want to vaccinate them again when they are pregnant, hopefully at least 2 weeks before they deliver their baby, so those maternal antibodies can cross that placenta. So those risk groups that are available for the nationally funded immunisation program are all of these that are listed, and once again I won't go through reading them all. So those of you that are vaccine providers with the nationally funded vaccine program would be receiving vaccines into your fridges now, and these are the people that you would be vaccinating with those particular vaccines. In regards to the pharmacy sector, so pharmacists, the pharmacy program now can offer national immunisation program funded vaccines, and that includes influenza vaccine. And to be eligible for that program, pretty much every state will say that the patient must be aged 5 years and over at the time of vaccination and eligible to receive the NIP vaccine in a pharmacy and as per the NIP schedule and in accordance with state and territory requirements and legislations. So if you're a pharmacist, please check with your local legislations, because I know here in South Australia, for instance, pharmacists do have some exclusions to the flu program, and they cannot administer NIP vaccines for reasons outside of a specified program or schedule for the purposes of travel, the management of a tetanus-prone wound, or those listed as medically at risk, or to do catch-up schedules for children aged 5 years to less than 10 years. So there's definitely some exclusions here in South Australia, so check with your state and territory legislation. So I think this is a bit of a tricky question, when is the best time to administer flu vaccine? Because since 2019, we've really seen higher rates of interseasonal flu activity in all of the years except for 2022, because our borders didn't open, of course, until March that year, and there was very little flu in 2021 to carry through. So our flu season is often here before March, and we don't have vaccines in our fridges until they arrive on the private market in around mid-March. And then perhaps you're not getting NIP vaccines into your fridges until very late in March or even early April, depending on your delivery cycle. So where we would once have that peak notification in July or August and into September, we certainly have seen these really early and protracted, these exceptionally extended flu seasons, and looking at last year, flu was even here right through to December. But ideally, vaccinate people once you've got vaccine coming into your fridges, for sure. And yes, there is some talk that those first 3 to 4 months post-vaccination is the optimal level of protection, but the protection should last for the duration of the 12 months. Definitely the virus is always changing. We talked about that antigenic drifting, so important for people to receive the current year's influenza vaccine. We've already talked about who should be receiving the 2 doses, but some people that might be travelling later this year from the southern hemisphere and going to the northern hemisphere winter, where the flu is going to be circulating, may well benefit from having a second dose of southern hemisphere vaccine before they depart. However, please explain to them that the strains that are circulating in the northern hemisphere may not be a good match for the strains that are in our southern hemisphere flu vaccine. So bottom line is just keep recommending flu vaccine to everybody, because we know that health care professional recommendation does increase flu vaccine uptake. Just very, very quickly looking at the strains that are contained in the flu vaccine this year. We've got our egg-based strains and we've got our cell-based strains. We don't have recombinant flu vaccines in Australia, but we do have a cell-based one. You will notice that the A strains are different in those 2 vaccines, and that really is because the candidate vaccine viruses recommended for H1N1 and H3N2 just might differ because they just need to work best in the different production systems that are used. So sometimes they will change them out. Obviously, growing flu viruses in eggs can cause some change to the flu virus, and that's called egg adaptation. And that just may mean that the virus that goes into the vaccines may have changed a little bit from the virus that was selected by the World Health Organization to go into the egg. Whereas the cell-based, being mammalian cells, which we'll talk about shortly, there's no egg adaptation that actually occurs. So these are the vaccines that are registered and available for use in Australia this year, and the little white boxes that you can see on your screen are the funded program vaccines. So the ATAGI statement is now available, so please make sure that you do have that, and please make sure that you do those 3 vaccine checks before you administer any vaccine, and make sure that you check the AIR to make sure that the person hasn't already had a dose recently, and if they are eligible for 2 doses, making sure you observe that 4-week minimum interval. But those 3 vaccine checks, making sure you've got the right vaccine for the right age group. First check at the fridge. The second check the box off with your patient or the parent of the child and show them that this is the vaccine that you are going to be giving that particular person, showing them the expiry date, showing them that it's a 2024 vaccine, and then a third check just prior to administering the vaccine. So, that cell-based vaccine, it's a vaccine that's a subunit vaccine. It's propagated in maiden Derby canine kidney cells. It's an immortal cell line that was established with canine kidney tissue that came from a healthy Cocker Spaniel dog back in 1958. And that cell-based technology, it just offers the potential for a better match than the egg-based vaccines to what flu viruses are actually circulating. Just might improve efficacy just because there's going to be no egg adaptation, and particularly for H3N2. H3 is a problem. It doesn't grow well in egg culture. So hopefully, a non-egg-based vaccine may be able to increase efficacy a little. We've got enhanced vaccines, so we've got Fluad Quad, which is on the funded program for our people over 65 years of age. This is not available on the private market. The one that is available on the private market that is suitable for people aged 60 years and older is Fluzone High Dose. The Fluzone High Dose vaccine is an egg-based flu vaccine, but it does contain 4 times the amount of hemagglutinin per strain per dose, and it does not have an adjuvant. Whereas the Fluad Quad that we use on our national program, it is an egg-based vaccine, but it has an adjuvant which we are hoping and seems to improve the immunogenicity in older people. So it tends to wake up those aging immune systems. So obviously, efficacy and effectiveness will depend on the immunocompetence of the individual that's receiving the vaccine, as well as how well does the vaccine match the circulating strains. So if we're looking at quadrivalent vaccines, this is your just a standard egg-based vaccine, so around about 54-59% against laboratory confirmed influenza in healthy adults under 65 years, about 65% against laboratory confirmed flu in those little children. If we look then at the enhanced egg-based vaccine, so this is the adjuvanted vaccine, you can see for people over 65, there is a reasonable marked difference there in preventing hospitalisation from influenza or pneumonia than a standard influenza vaccine. The high dose vaccine, very, very good percentage in affecting, effectively preventing the hospitalisation, pneumonia, etc., than a standard egg-based vaccine. So then your cell-based vaccine, of course, is egg-free. It doesn't have that egg application possibility, but ATAGI do consider that both egg and cell-based vaccines are equivalent. They're not preferentially recommended one over the other. There was a small study that was done across a 2017-2018 season in the Northern Hemisphere in people over 65 that found no significant difference. But, for other studies where they looked at more than one flu season, they looked at 3 subsequent flu seasons, then there was some difference with H3N2 year, if that was circulating. But I think there just needs to be more data to come forward, to be honest. Adverse events, very, very quickly here. I think they're just like any other vaccine. They're usually very mild, short-lived. People with egg anaphylaxis can safely be vaccinated with egg-based vaccines. The question that's always raised is around Guillain-Barré syndrome, and there is a guide for GBS as a clinical pathway on the OSVAC safety website that would just say the guide recommends that if a patient developed GBS within 6 weeks of having an influenza vaccine, there is a small risk of recurrence of GBS following revaccination, but it really needs to be outweighed with the risk of not vaccinating somebody. Andrew sort of alluded to these stats before and drew your attention to the 6-month to 5-year-old children, but the long and the short of this slide is that every single age cohort has suboptimal coverage, and let's hope that we can do better in 2024. Obviously, flu and COVID are going to be circulating again this winter. We've also got RSV. Yes, COVID and flu vaccines can be co-administered on the same day. Not a problem at all. There's a lot of confusion around what disease do I actually have, what is the infection? And this is a nice little pictorial, I think, from the Commonwealth that you might like to pop up in your practices. But really, PCR testing is going to be the only way to truly identify which pathogen is causing that individual's illness. So we just really need to make sure that all of you wonderful nurses out there that have got so many touch points with your patients, that you are really going to be advocating for flu vaccine and using those opportunities. Every opportunity that you have to talk to somebody is an opportunity to potentially get them vaccinated. So you play a crucial, crucial role in increasing vaccine uptake in practices. Everyone loves a nurse. You're well trusted, you're really trusted, and you're really, really credible, and you can really just talk to patients just so well. So just wrapping up, I think we've really highlighted that, there is severe disease. There's certainly people that have got increased risk factors, your diabetics, those with heart disease, lung disease, etc., your pregnant women. Of course, those children, we've got free flu vaccine for children under 5 on the NIP. We need to be able to get this vaccine into these young children, and using every contact that we possibly have to talk to people about flu vaccination and the benefits of it. So take home, keep offering it, use every encounter. Even if you're doing another vaccine for another reason, if they're travelling, use this to talk about flu as well, and just offer it to every single person aged over 6 months that comes into your practice. So thank you. And I know that we're spot on time, and that's because of all of our technical difficulties, and I'm terribly sorry about that.
That's okay. Thanks, Angela. I mean, wonderful presentation. You covered so much. So we've had a lot of questions. It is 7 o'clock, but there's been so many good questions. I've been frantically writing them down. For those that want to stay. For those that it's 7 o'clock, you want to go, then you can go. However, we will provide the full transcript of questions. And for those questions that we cannot answer or have not answered, we'll provide these, but for those that we do answer, we'll see if we can still provide answers to those and send those through as a transcript early next week, together with the link with the video and the PowerPoint. So here we go, rapid fire questions. Are you ready, Angela?
Yes.
Uh,
Yes.
right, okay, here we go. So effectiveness of this year's vaccine,
Yeah.
is it predicted to last the whole season, or what should I do? Wait until later in the year to cover the winter months or not? So it depends really when
Look,
they first vaccine.
yeah, look, I think definitely vaccinate people now. We've got high flu notifications, as we've already alluded to, so we need to protect people now against disease. We don't know how long the season will last, and we don't know what really is going to be circulating and whether the vaccine's going to match what's circulating well. If it's a H3 year, then we're in for a bad year, full stop, because we always do with a H3 year.
Thank you. Can fluad quad, which is indicated for 65 years and older, be given at the same time, which is the same day as Shingrix? I know the answer to this, by the way.
Yeah, yes, absolutely. Use every opportunity, co-administer in separate limbs. There's not a lot of data about the co-administration with these two adjuvanted vaccines. However, ATAGI would say they can be co-administered on the same day, but given the lack of data, it's okay to separate them by a few days if you choose to. But I'd be co-administering myself.
Okay, thank you. Yes, that's the answer. That's true. So, first time question. We've already covered this, but it's an FT question. Some of us have already received the 65 plus fluid quad, and it didn't say when. Could have been late last year or early this year. Do we have to wait for the program to commence in order to get the 2024 vaccine?
Yeah, so if you had a 2023 vaccine earlier this year, definitely you will be coming in for a 2024 formulation vaccine, most definitely.
How many deaths have been caused this year by influenza? I know 2023 because I looked it up yesterday. It was 279, but I don't think we've got data
Yeah.
before, have we?
We haven't got a lot of data yet for 2024, but I did hear the other day, today I read that Queensland have recorded 11 deaths
Yeah.
themselves. And so I think, we'll learn over the season how many, but yes, deaths have started, absolutely.
Right, and off memory, those 279, the medium age was 77, as you would kind of
Correct.
expect. Um, Do the flu notification numbers come from laboratory confirmed
Yeah.
only? Yes, is the answer.
Yes, they do. Yes. So
Yeah.
that's why it's so underreported, because not everybody has a swab put up their nose to get it confirmed.
Yeah. All right. So you've covered the second dose question, but I'll ask the second part. Are both covered under the NIP if you're eligible?
Yes, absolutely. Yes, correct. Yeah, they
Yeah.
are.
Hmm. Will someone ask for references for increasing risk of cardiac patients after influenza? I've got a whole bunch of those, so I'll provide those. And we did
Great.
a webinar on that earlier last year, so I can provide that.
Mhm.
Um, so a few patients over 65 have refused to receive Fluad Quad because of the vaccine side effects. Patients are happy to get Vaxigrip or Fluarix Tetra on private.
Mhm.
What's your recommendation? Considering, and I looked it up, it's not recommended for that age group.
Yeah, look, they're licensed to be given, and Atagi would say that the adjuvanted vaccine for over 65s is preferred over a standard egg-based vaccine, because the standard egg-based vaccine does not excite those aged immune cells that we want to excite. So they're not going to elicit as much coverage as what the adjuvanted vaccine will do for an older person.
Have you heard of, and there are many subtypes of this, the H1N1, H3N2 that I'm aware of, but have you ever heard of HN? I haven't heard of that.
There's lo- Well, there is a whole list, and maybe I can find that, Andrew, and send that through that you can include in any communications, because there is actually there is a slide that I've seen with all the H's and all the N's. So yeah, we can find that for you.
Okay. And just confirming, WA is giving someone made a comment. It is free vaccination for all in May and June. So if
Yeah, yeah.
obviously came on late, and that's fine, that's good. Pharmacists, do they require immunization training as do nurses?
Actually, the pharmacists had probably more training than the nurses, to be really quite honest. Yes, they have quite extensive training, and they must attend, after all they've done all of their online courses, they then must attend a full day competency assessed immunisation workshop, where they actually do inject each other with normal saline and all sorts of things. So no, they're very well trained, and after 11 million COVID vaccines administered out of pharmacy, I think we can say they're pretty safe vaccinators.
Absolutely, absolutely. Uh, just maybe one more question. So still 300 people online, and it's nearly 10 past. Uh, Flucelvax, which is recently recommended on the NIP and funded on the NIP for 5 to 64s with medical conditions. Why has that made the NIP? You have kind of
Yeah, well, yes. Look, I'm not a decision maker, because the other point, really, that is part of this answer is the fact that this particular vaccine is actually licensed to be used in babies from 6 months of age, and yet the NIP, for whatever their reason, have just chosen it to be from 5 years of age. So it's available on the private market for anyone over 6 months of age, but um, I can't answer. I'm not government. I don't know why what was the reason for this year to accept it, where it's been around in Australia for the last 4 years, or the last 3 years. And it didn't make the NIP. So it just might be a timing thing.
It will also gives good choice for those that have egg allergies. So
Yeah, look, even though we know that people with egg allergy can still be safely vaccinated with an egg-based vaccine, if the person is super nervous and it means them not having a vaccine because you can't convince them that it's safe, then yeah, it's a different option for sure for those people. Yeah,
okay, I think we'll wrap it up there. There were a few other questions, but it's 10 past 7 and just want to
sure.
respect everybody's time. So thanks very much, Angela. That was an amazing talk, and thank you for all your answers to your questions. And thank you for the audience for putting the
Yes, thank you.
particularly those two first time participants putting their questions forward. So the next webinar update is on COVID-19. It's presented by Professor Gary Groman on the 14th of May. So you can go online and register for that. You can find that on our website. We also provide it out on our newsletter, so click the link and it will take you directly to the registration page. There's also something else that's coming up on the 17th of May. It's a influenza COVID-19 RSV webinar series. There are no slides. It's a panel discussion. There's GP present, there's a specialist present, the pharmacist present, a nurse present, and someone from mobile vaccination services. So it's a 5-person multidisciplinary webinar series starting on the 17th of April. Slightly different people on the 22nd of May and then the 19th of June. So it's going to cover the respiratory virus kind of season or leading up to the season and through the season. And they're going to focus around discussions, not canted, but centered around numbers of cases, vaccine coverage rates, and options to increase the number of vaccinations through primary care and pharmacy. So do look out for that. It'll be on our website. It is on our website, so you can register for that. And it's a 3-series webinar. It is CPD accredited. There's a short survey coming your way. It's probably been sent to you now. If you do have a chance to fill that out and send that back, that'd be tremendous. So with that, I'm going to say good night. Thank you again for your participation. Thank you, Angela.
Thank you, Andrew, and thank you everybody for attending. Stay safe.
and good night.
Good night.